All right. Hello, everyone. Welcome to today's presentation. I am Paulina Milana with the Los Angeles Family Caregiver Resource Center here at USC. We focus on Los Angeles County family caregivers, providing information and support services to those who are caring for older adults with brain impairments or multiple health concerns. LACRC at USC has been empowering family caregivers in the Los Angeles area since 1989, and we're part of a statewide system of 11 caregiver resource centers throughout California. Now, if you haven't already, do go check out our website. It's losangelescrc.usc.edu. We're putting the link in the chat. You will find so many resources there, all for free. So please tool around and see what might fit with whatever you're in need of at the moment. If you haven't already, excuse me, signed up to get our email alerts, you'll want to do that too. And I'm going to ask for the link for that to be put into the chat. We'll also share the link to our presenter today in just a few minutes. I know you are all here to learn more about today's topic, which is on Medicare and Medicaid. Here in California, it's called Medi-Cal. Sometimes that's confusing because it's called all sorts of things throughout the nation. But we are honored to have the program director, Stephanie Fajuri from the Center for Healthcare Rights, who is going to introduce herself because, as I told her earlier, she has so much to her background and so many insights that she'll be sharing with us that she'll do a better job, I think, in letting us know who she is and what she is going to be presenting to us today. Also, just so you know, because I know we get questions like this in the chat, after this presentation, we will send out the replay. We also will send out the PDF of the slides. And we have another special document that we will be sharing with you from Justice in Aging that has to do with Social Security. A lot of great info on that that I'll be honest, I did not know myself. It may surprise you some of what is on that sheet and what we can do about it with the changing times. So without further ado, I'm going to turn this over to Stephanie. Thank you so much, Stephanie, for today. We really appreciate this.
Thank you so much for having me. So, yes, my name is Stephanie Fahuri. I am the program director at the Center for Healthcare Rights. I've been with Center for Healthcare Rights for a little over 5.5 years. Before that, I was with Disability Rights Legal Center, and I ran the Cancer Legal Resource Center, which is a program that provides free legal information to people coping with cancer. So, I'm originally from the Midwest. I am an attorney. I'm licensed in California and New York, and I'm a very proud Michigan Wolverine. So without further ado, let me see if I can go ahead. Oh, I cannot share my screen.
Um, hmm.
There we
Wait.
go.
Oh,
Got it. Okay. So let me share my slides here.
and Stephanie, if I can just interrupt really quickly, we will be taking questions at the end. So if you do have questions, feel free, you can jot them down or pop them into the chat and we'll take them before we end this conversation. All right, that's it for me. Thank you.
Thank you. Okay, so we are going to be talking today about Medicare and Medi-Cal updates. Obviously, I will share some background information, not just updates. So here's a little overview of what we're going to review today. First, who's Center for Healthcare Rights, right? Why am I the one that's here talking about any of this stuff with you all? We'll do a brief Medicare overview. We will also do a bit of an overview with respect to Medi-Cal, including updates that have taken place recently for both programs. We'll talk about how Medicare and Medi-Cal work together. And then we will also talk a bit about coverage options for dual eligible beneficiaries. So that's people that have both Medicare and Medi-Cal. I'm Paulina said, I am very happy to take questions at the end, but I do want to assure you that if you have questions that I am not able to answer today, you have other opportunities to get in touch with my program. So, I am the program director at Center for Healthcare Rights, which runs the Health Insurance Counseling and Advocacy Program, or HICAP, for the city and county of Los Angeles. So, what does that mean? What does HICAP do? HICAP provides free education and assistance with Medicare and other related health insurance to Los Angeles County residents. Our service area is all of LA County, and we provide services to people with Medicare at any age, as well as their family members, caregivers, etc. Now, one of the things that I think is important to understand about Center for Healthcare Rights, we are an independent nonprofit organization that is primarily government funded. But because we run this high cap program, we are not allowed to work with any specific insurance companies. We do not endorse or recommend any specific insurance plans. We provide neutral and unbiased Medicare information. So you don't have to worry that I'm going to be trying to pitch you on any specific type of plan, because we understand that there is no one size fits all insurance coverage option, even for people who have Medicare and Medi-Cal. People have different needs. So when I said that I might not be, if I'm not able to answer all of your questions today, you may be able to get in touch with us for some one-on-one assistance. You can do that in a couple of different ways. Our website is in the chat, healthcarerights.org. Feel free to hop on there. And there is a section on our website where you can request a counseling appointment. Someone will call you over the phone to schedule that appointment for you. You can also call us directly. The statewide high cap number is here on the slide, 1-800-434-0222. For anyone who's ever received a copy of the Medicare and You book, which usually goes out every fall, our phone number, that same phone number, is on the back cover of that book. There is a program like ours in every county in California and in other states. Just like Paulina mentioned, Medicaid is called different things in different states. The high cap program is called different things in different states. So we're part of what's called the SHIP network, State Health Insurance Assistance Program. There's resources available in every state like ours, providing free, unbiased, one-on-one Medicare assistance. We also have a volunteer counseling program. They go through the same rigorous training that all of our staff counselors do, and our volunteer counselors primarily are providing assistance in person. So we can do telephone appointments, or we can do in-person appointments depending on where you live and what's more convenient for you. Okay, so with that, let's talk a little bit about Medicare. I think one of the things that comes up the most is, well, what are all of these different letters? What do these different parts of Medicare cover? So there are technically three main parts to Medicare. And you might be looking at the slide and saying, well, Stephanie, I see four parts listed there. What are you talking about? I promise that I will make this clear. So the three main parts of Medicare are Part A, Part B, and Part D. So Part A is the hospital coverage. That is what covers people when they are admitted to the hospital, staying overnight, usually at least 3 nights. But it is a hospital stay inpatient covered by Part A. Part A also covers skilled nursing care in a skilled nursing facility, home health care, hospice care at the end of someone's life. So that's typically inpatient services, although hospice is often provided at home. Now, Part B, as in boy, is the outpatient services, or what they call medical services. So Part B going to the doctor, getting lab tests, x-rays, durable medical equipment like a wheelchair or a CPAP machine or a continuous glucose monitor, um, preventive care like cancer screenings, flu shots, annual wellness visits, and other types of outpatient therapies are all covered under Medicare Part B as in boy. And then that third main part of Medicare is Part D, which stands for drugs. So I think Part D is the easiest one to remember because D stands for drugs. Now, you might be wondering, well, why did you skip Part C? I skipped Part C because Part C is what is also known as Medicare Advantage. And I like to think D stands for drugs. I like to think C stands for choice. C is an option. It is not a required part of Medicare. Instead, it is an optional way or a choice you have to combine your Medicare coverage into one private insurance plan that then contracts with Medicare to provide the hospital, medical, and prescription drug coverage. So we'll talk in more detail about Medicare Advantage in a little bit, but think of C as standing for choice. It is not a required part of Medicare. It is an optional way to receive your benefits all together in one plan. And I apologize in advance. My cat is sitting between me and my laptop and may make a cameo on this webinar. Okay, so now that we have a sense of what are the different parts of Medicare cover, who's actually eligible for Medicare? Most people become eligible for Medicare at age 65. And if you are 65 or older and a US citizen or a green card holder who has lived in the US for at least 5 continuous years, you may be eligible for Medicare. The only way for people to become eligible for Medicare under age 65 is if one of three things is true. One, they have received Social Security Disability Insurance, SSDI, for at least 24 months, so 2 years, or they have end-stage renal disease, or they have ALS, also known as Lou Gehrig's disease. So those are the only three ways that people under the age of 65 can get enrolled into Medicare. Otherwise, you do have to wait until age 65. So when can you sign up for Medicare? Well, everyone who becomes eligible for Medicare has what's called the initial enrollment period, which is a 7-month period that surrounds the month of eligibility. So for most people, that month that Medicare would become active is the month that you turn 65. For folks on disability, that would be the 25th month on disability. But again, for most people, it's the month that they turn 65. So, for example, my birthday is in October. So, once I'm eligible to enroll in Medicare, my initial enrollment period will start 3 months before the month I turn 65 and will finish 3 months after. So, since my birthday is in October, that means my initial enrollment period would start July and would include July, August, September, would include the month of my birthday, October, and then would also include November, December, January. Now, a lot of people who are still working at age 65 and have employer group health coverage might decide to delay their Medicare enrollment. They might qualify for a special enrollment period later on. But one thing that I would like to encourage you, for those of you who maybe have not yet reached age 65, the initial enrollment period, I think, is the best time to contact the HICAP program to get a good sense of what do I need to do? What are my options? Is it okay for me to delay coverage or should I enroll now? What are the things that I need? Because I hear from people all the time who say, oh, I never knew I needed to do XYZ, or I thought I got advice from a friend and they told me I could do, ABC, and it turns out that was wrong. Just come straight to the experts. We're not going to sell you anything. So our services are free. I think that initial enrollment period is a great, great time to do your research, talk to people who are experts, and get that unbiased opinions about what to do without having to worry about being sold a plan that you maybe don't want. Now, there are other times but you can sign up for Medicare coverage. So right now we're in the general enrollment period. It starts January 1st and goes through March 31st of each year. This time of year is typically for people who have missed their initial enrollment period and lost their Part B coverage because they stopped paying for it or something like that. So this is the time of year where if you happen to be missing coverage and don't qualify for any sort of special rule to sign up, you can always sign up during, January through March. Now the open enrollment period in the fall, October 15th to December 7th, is the time of year that if you are anywhere close to Medicare eligibility, you're probably getting inundated with mail. You're probably seeing tons and tons of TV commercials, maybe even radio ads, social media ads to sign up for different plans. That's because the open enrollment period in the fall is for making changes to drug coverage, whether that is a standalone drug plan or part of one of those Part C plans, Medicare Advantage plan. So, open enrollment in the fall is not necessarily for signing up for Medicare for the first time. It's for people that already have Medicare to look at their options for the following year and decide, do I want to change my coverage or not? And then, as I mentioned before, there are sometimes some special enrollment periods that might make someone eligible to sign up for Medicare outside of these other periods. They have to make it complicated, right? So, let's talk a little bit about how much Medicare costs. For most people, Medicare Part A coverage, that hospital coverage, is free on a monthly basis. If you have worked and paid into the Social Security system or paid that Medicare, that FICA payroll tax for at least 10 years, you will have 40 work credits or work quarters with Social Security, which means when you turn 65, you will be eligible to enroll in Medicare Part A with no monthly premium. Now, this says automatic enrollee because if you are already receiving any type of Social Security benefit, whether that's retirement benefits or if you're on disability, SSI, any of those Social Security benefits, when you turn 65 or when you become eligible for Medicare, you will be automatically enrolled into Medicare Part A. Now, I know a lot of people these days have to keep working after age 65. LA County in California are very expensive places to live. The United States is an expensive place to live. So lots of people are working well past 65, full retirement age for Social Security benefits for most people now isn't until age 66 or even older. People also know that you can maximize your Social Security benefits if you wait until age 70 to start collecting. So, this is not necessarily tied to whether or not you are actually getting your Social Security. Regardless of whether you want to delay your Social Security retirement benefits, Medicare eligibility still starts at age 65. Like I said, most people don't pay anything for it. There are some folks that do not have enough work quarters with Social Security where they would have to potentially pay for Medicare Part A coverage. And then for folks that have very low income, including all SSI recipients, supplemental security income, who have very low income, very limited assets, some folks will now be as of January, are being automatically enrolled into a program that will have the state pay their Part A premium for them. Excuse me. Sorry. Okay, so moving on to Part B. Part B, that medical coverage, does have a monthly premium for most people. If you're receiving Social Security retirement benefits or disability benefits, this premium is often deducted automatically from the Social Security check. Again, for folks that are delaying that Social Security payment, they may have to set up a payment plan through something called Medicare Easy Pay, or you can pay quarterly, but there is a monthly cost. People on Medi-Cal do not pay this. The state pays that for them, but I'll talk more about Medi-Cal in a little while. But for folks not on Medi-Cal, earning under a certain threshold, this is the monthly premium for Part B this year. And the reason I wanted to talk a little bit about those enrollment periods at the beginning is because there can be pretty negative consequences to signing up late if you don't know the rules. So, if you just decide, you know what, I'm healthy, I don't have any health insurance coverage, I don't need health insurance, I'm not working and covered through myself or a spouse, just I don't need coverage. And then you decide to sign up for Medicare late, you can face lifetime late enrollment penalties, which are very substantial. I have spoken with people who, for whatever reason, lost their coverage or didn't enroll in time and ended up with 20%, 30% penalties added on to their monthly premium for the rest of their lives. I would love to help you avoid that. Now, again, if you have Medi-Cal, this is not something that you need to worry about paying because the state does pay for you. Now, you may have heard that Medicare covers 80% of your healthcare costs, and then you're responsible for 20%. So if the only coverage you have is the red, white, and blue Medicare card that shows you have hospital and medical coverage, right? Parts A and B, you will face out-of-pocket costs. So Part B this year has a $257 annual deductible. That's how much you pay out of your pocket before Medicare pays for services. There are some things that are exempt from that, like certain preventive services. You don't have to worry about meeting the deductible first. But the big thing here is that, yes, Medicare covers 80% of the Medicare approved charges. And without any other secondary coverage or supplemental coverage, or without a Medicare Advantage plan, the beneficiary or the person enrolled in Medicare is responsible for 20% of the Medicare approved charge. Now, on its face, that might not seem like the end of the world. Okay, 20% is, it's better than being on the hook for all of it or for half. But then you start thinking, well, what's the Medicare approved charge for blood work? Or what's the Medicare approved charge for an MRI? Right? If you end up in the emergency room, which is outpatient care covered under Part B, and your doctor recommends, x-rays, an MRI, blood work, and, observation from a number of different physicians, you could end up with a pretty hefty bill that you have no idea what it could possibly be because you don't know what the Medicare approved charges are. So this is a big reason why people will get some type of secondary coverage. If you have Medi-Cal, you don't pay this. So that having Medi-Cal is a great way to avoid having to potentially go into medical debt because you owe 20% of Medicare approved charges. Now, as I mentioned before, their Part D is the other main part of Medicare. And there are two ways to get prescription drug coverage through Medicare. So the first option, and this slide is for my visual learners. So I mentioned the red, white, and blue Medicare card, right? It's a paper card, kind of like your Social Security card. It's not plastic. That surprised me the first time I saw one in person. But the red, white, and blue Medicare card shows you Part A and Part B. It is an open network. You can see any doctor that accepts Medicare. And if you want to go the original Medicare route, you get what's called a standalone prescription drug plan or a Part D plan. The other option is what we talked about before, which is referred to as Medicare Part C. It's also called Medicare Advantage or Medicare Advantage Prescription Drug Plan. typically covers parts A, B, and D all together in one plan. And these Medicare Advantage plans are what's called managed care plans. So they have HMOs, there are PPOs, there are certain types of special needs plans, which I'll talk about in a bit. But Medicare Advantage is a managed care plan run by a private insurance company. So if you think to yourself about, the name of any insurance company, they probably sell a Medicare Advantage plan here in LA County. Kaiser is a very popular one. Scan, United Healthcare, AARP United Healthcare, WellCare, Blue Cross, Anthem Blue Cross, Blue Shield of California, Central Health Plan. There's a lot of different options. I'm just using those as examples. We do not, as I said, endorse any plans, but it's a private plan. Whereas when you have original Medicare with a standalone drug plan, the drug plan is run through potentially one of those same insurance companies I just mentioned, but your medical and hospital services are paid directly by Medicare. So when we're talking about the prescription drug coverage through Medicare, in 2025, there have been some big changes. Um, every year, the standard deductible goes up. So, I had mentioned the deductible is how much you pay out of your pocket before the plan or before Medicare kicks in. So this year, the standard deductible, I think it says 590 here. I thought it was 595, but it like that's a significant amount of money. For some plans, they have a $0 deductible, which means you go to the pharmacy and you're immediately paying just a copay or a percentage, as opposed to having to pay that much money out of your pocket before the plan kicks in. Now, in the past, you may have heard of the term the coverage gap or the donut hole. That is a thing of the past. I am so delighted to tell you that we no longer have to worry about talking about a donut hole. We can leave that to Dunkin' Donuts and their munchkins, right? So now, once you have met your deductible for your drug coverage, which might be zero, like I said, some plans do not charge a drug plan deductible. They might spread out those costs by charging a monthly premium that's a bit higher, but some of the Medicare Advantage plans do not charge a deductible at all. But essentially, once you've met that deductible and your out-of-pocket costs reach $2,000 for your prescription drugs, you will then enter what's called the catastrophic coverage phase and you will pay zero. So basically, what all of this means is there is a $2,000 out-of-pocket maximum for drug coverage through Medicare. This is a big change. So we're very excited about it. Now, there is a program that can help reduce costs for Medicare prescription drug coverage. It's called the Extra Help Program or the Low Income Subsidy Program. Our agency screens every single client that we speak with for this program because some people don't realize that they might be eligible, and it really can make a tremendous difference in whether or not someone can actually afford their prescription drug copays. Now, you can apply for extra help directly on the Social Security website. It is a very easy application. I think there's maybe like fewer than 10 questions. It's pretty straightforward. They compare data to what they have, with the IRS or other data sources because this is a federal agency. So you don't even have to upload documents. They do, the evaluation based on information that they have access to. But this program is extremely helpful, and it does have strict income and asset limits. So if you are applying for the Extra Help program directly through Social Security, the income limits this year are 1976 for an individual, 2664 for a married couple, and then there are asset limits as well, around $17,000 for an individual, around $35,000 for a married couple. Now, you might be thinking, well, what does this get me? There are prescription drug plans that you could sign up for $0 per month. And those plans also have a $0 deductible. So, right off the bat, that saves you money on a monthly basis and at the pharmacy. And then rather than having to worry about prescription copays that might be a percentage, especially if you're taking some type of specialty drug, some of those can be wildly expensive. The prescription copays are no more than $4.90 per month for a generic drug and no more than $12.15 for a brand name drug. And one of the stories that I'll tell really quickly is that one of my dear friends is an oncology nurse practitioner, and one of her patients was prescribed a very expensive oral chemotherapy drug. And the copay was going to be, or I should say the coinsurance, because it was a percentage, it was a specialty drug. The coinsurance was going to be more than his monthly income. And he did not want to apply for Medi-Cal for whatever reason. He was just insistent he did not want Medi-Cal, but he wanted to be able to fill his prescriptions that he needed to treat his cancer. So she contacted me. We helped him apply for the Extra Help program and got his prescription drug copays down to it was 11 something last year, I think 11.55. So instead of having to pay $1,300 a month or whatever the coinsurance was going to be, he was able to get it down to a manageable level where he was going to be able to actually take the medication as prescribed and fill those prescriptions when needed. So this is really a life-changing program. Now, we've talked a little bit about Medicare now, right? So we've got parts A, B, and D. One option to get coverage is through one of those Medicare Advantage plans, which is also known as Part C. Um, Eligibility for Medicare is based on your age. Are you 65 or older? Or are you on disability or have one of these two other disabling conditions? And then you have to be a US citizen or a legal permanent resident who's lived here for at least 5 years. There are very different eligibility rules for Medi-Cal. As Paulina mentioned, Medi-Cal is the name of the Medicaid program here in California. They are not two separate programs. I have spoken with clients before who said, yeah, I have Medicare, I have Medi-Cal, but I was told I have to sign up for Medicaid also. Nope. If you've got Medi-Cal, you have Medicaid. You are enrolled in the California version of the Medicaid program. So Medi-Cal bases its eligibility on income limits. And actually, I need to update this slide because this no longer makes sense here. There used to be asset limits for older adults and younger people with disabilities, but those asset limits have gone away. I will update the slides before they get sent out with the recording so that this is not confusing. But I also wanted to flag that the state of California did update its benefits identification card for Medi-Cal several years ago. Some people I talk to still have this older version, this blue and white version with the state seal of California. Some people have the newer version that has the state flower on it, the poppy. Either one is fine. If you have the old one, you don't have to get rid of it. But this is one of the ways that I can help people understand what type of coverage they have. Because usually someone will say, oh, I'm sure I have Medicare. I know for sure I have Medicare. And I say, well, do you have the red, white, and blue card? And they say, no, I have a card that just has some flowers on it. Then that indicates to me they only have Medi-Cal. So this can be really helpful to figure out, well, what coverage do you have? Look at the cards in your wallet, look at what you've received in the mail. The red, white, and blue card is for Medicare, and then Medi-Cal has one of these two options. So for our program, because we are primarily focusing on older adults and people with disabilities, these are the Medi-Cal programs that we have the most experience with, which is SSI linked Medi-Cal, For people who receive supplemental security income, they do not need to submit a separate application for Medi-Cal. They are automatically enrolled into the Medi-Cal program. Most of our clients that we talk to have either the Aged, Blind, and Disabled Federal Poverty Level Program, ABD-FPL. That's for people that are 65 or older, blind, or receiving disability benefits. Or if their income is a little bit over the income limit for the ABD-FPL program, they might have what's called the medically needy program, also known as Medi-Cal with a share of cost. We get a lot of calls about Medi-Cal share of cost. Now, for some people who are receiving disability related income, they may be able to enroll in a separate program called the 250% Working Disabled program. Um, it's a little complicated. I'm not going to spend much time talking about it right at this moment. If there are questions later, I'm happy to answer. But it is essentially for people with disability related income, especially if their income is over the limit for the Aged and Disabled program. This program can help them qualify for full benefits without having to pay a share of cost. So, for the Aged, Blind, and Disabled Federal Poverty Level Program, there are no longer asset limits, as I mentioned. None of the Medi-Cal programs have asset limits. So, when we're talking about assets, we're looking at property, we're looking at bank accounts, retirement accounts, savings bonds, other types of personal property. They no longer care what kind of money you have in the bank or what kind of property you own. This is a really exciting thing that the state of California has done. That said, there are still income limits. So, in order to be eligible for full Medi-Cal coverage through the Aged and Disabled program, the income limit is 138% of the federal poverty level, which right now is $1,732 per month for a single person or $2,352 per month for a married couple. But those income limits go up every April 1st. Now, I know it's confusing. Why doesn't it just go up January 1st? These non-Magi Medi-Cal programs are treated slightly differently. For whatever reason, the state has decided that these income limits for the Aged and Disabled program go up April 1st. So as of April 1st, the new income limit will be $1,801, and for a single person and $2,433 for a married couple. So again, the Medicaid rules vary from state to state, and I say that here because although the Medicaid program is jointly funded by each state and the federal government, the states are the ones that are administering the program. Medicare is all handled at the federal level, but Medi-Cal is really a state program that gets federal funding. So in other states, there are still asset limits. In other states, the income limits might be lower, they might be higher. It really varies from state to state. So if you are in a situation where you have Medi-Cal here and you are thinking about moving to another state, you are definitely going to want to make sure you understand what the rules are in the state you're moving to, because it is entirely possible that you have benefits here that you will not have access to if you move to a new state. Medi-Cal does not transfer automatically. You would have to become a resident of the new state and then apply for their benefits under their rules. Unfortunately, a lot of other states are not as generous as California is. So as expensive as it is to live here, we do have access to certain benefits that other people do not. And this includes access to full Medi-Cal coverage for undocumented immigrants. So our agency does work with undocumented immigrants. A lot of the ones that we have, a lot of the individuals that we have spoken to came here with a valid work permit, worked here for 30, 40 years, retired, lost that valid work permit, no longer have legal status, thankfully, they can still get access to healthcare services through the Medi-Cal program. So if someone has Medicare and Medi-Cal together, how does that work? Well, Medicare is the most important or primary insurance. Medicare is the first payer. It is the network that you would go through. Medi-Cal pays as secondary coverage. Um, if you have Medicare and Medi-Cal, you can typically go to any doctor that accepts Medicare who will also accept Medi-Cal as secondary coverage. I will give the caveat that there are some doctors that say, sure, I accept people who have Medicare. I, get reimbursed by Medicare. I'm happy to submit bills to Medicare. But some providers will say, I do not want to take on a new patient who has Medi-Cal as secondary coverage because Medi-Cal doesn't pay that full 20%. And some doctors want to get their full copay amount. Now, one question that comes up is, well, I was required to pick a managed care plan for my Medi-Cal, but my doctor says they don't take that plan. My doctor says they don't take Health Net, or my doctor says they don't take LA Care. That's okay. Medicare is the primary insurance coverage, which means the only question that needs to get asked of the doctor when making an appointment is, do you take Medicare as primary and Medi-Cal as secondary? They do not have to be in the plan network for the Medi-Cal plan. Now, if someone has a Medicare Advantage plan, that is a different story. You would have to go see a doctor that is in the Medicare Advantage plan network, and all of those doctors are required to see patients that are part of that plan, regardless of whether or not they have Medi-Cal as secondary coverage. So how does Medi-Cal close the gaps in Medicare coverage? Unfortunately, there are a lot of things that Medicare does not cover, like, as we talked about earlier, that 20% co-insurance, that Part B deductible, right? That's a gap in coverage. Having to pay money out of your pocket is a gap. When you have Medicare and Medi-Cal together, Medi-Cal covers the deductible. You are not allowed to be billed for co-payments or deductibles. Medi-Cal pays the Part B premium, which this year, as I said earlier, is $185 per month. And then Medi-Cal also provides extra benefits that are not covered by Medicare, like vision. I wear eyeglasses, right? Medi-Cal covers vision, dental, hearing aids, incontinence supplies, transportation to doctor's appointments. So Medi-Cal can help bridge a lot of those gaps. Now, in Los Angeles County, these are the Medi-Cal managed care plans. So as I said, you can be enrolled in Medicare, right? Original Medicare has that red, white, and blue card. But if you also have Medi-Cal, you will be required to select one of these plans to manage your Medi-Cal part of your coverage. So the biggest two, LA Care and Health Net, they do have some partner plans. Blue Shield of California and Anthem Blue Cross are partner plans with LA Care. Molina is under the Health Net umbrella. Kaiser is its own thing. And typically you can only join the Kaiser Medi-Cal plan if you already have a pre-existing relationship with Kaiser. I've had Kaiser coverage in the past. But this is something that gets very confusing for clients that I speak with who say, well, I thought I had Medicare and I said I didn't want to have an HMO. Why am I being forced to pick one of these? The state has decided that they want Medi-Cal to be part of managed care plan. So you will be required to pick one of these. But again, if you have original Medicare and you have LA Care as your secondary coverage, as your Medi-Cal, You don't have to just go to LA Care doctors. You can go to doctors that accept Medicare and ask them if they accept Medi-Cal as secondary. So, what does Medi-Cal cover? There's a lot of overlap with Medicare, right? So Medi-Cal covers hospital care, doctor services, prescription drugs, ambulance, etc. We talk to a lot of folks that have Medi-Cal first, and then once they turn 65 or once they've reached their 25th month on disability, then they get enrolled in Medicare. So there is overlap. When there is overlap, Medicare is going to pay first. So if you have Medicare and Medi-Cal and are admitted to the hospital, Medi-Cal is not going to be billed first for that hospital stay. Medicare will be. But then Medi-Cal will kick in its share afterwards. There are a number of benefits, as I just mentioned, that Medi-Cal covers that Medicare does not. Medi-Cal covers dental, eyeglasses, hearing aids, incontinence supplies, transportation, and then a big one, long-term services and supports like nursing home care, adult daycare, and then in-home supportive services is a really big one that we hear about from our clients and their family members and loved ones, because obviously most people would prefer to continue to age at home. And in-home supportive services is one of those Medi-Cal benefits that can really make it possible to delay nursing home care as long as manageable. So I do want to shift focus a little bit now to talk about some of the coverage options for dual eligible beneficiaries. So again, a dual eligible beneficiary is someone who has both Medicare and Medi-Cal. And here's my cat. So sorry. Um, so for dual eligibles, as I mentioned earlier in the presentation, anyone can have original Medicare with a standalone drug plan, right? On that slide, and I'll actually even go back to it just to show one more time. Anyone with Medicare and Medi-Cal can have either of these options, original Medicare, standalone drug plan, and then Medi-Cal as secondary. Or someone with Medicare and Medi-Cal could have a Medicare Advantage plan with a Medi-Cal plan as secondary. To go a little bit deeper into that, I want to share one third option, which is technically part of that Medicare Advantage umbrella. So there is a subset of Medicare Advantage plans, again, that Part C, that option, that choice option. And this subset of Medicare Advantage plans is called a dual special needs plan, or a D-SNP. We have a new system in place here in California where they are now referring to these D-SNPs as a Medi-Medi plan. A lot of times we've in the past have referred to people with both Medicare and Medi-Cal as Medi-Medis, right? You might have heard that term. Rather, dual eligible sounds very formal. Medi-Medi is sort of a colloquial term, but these plans are known as Medi-Medi plans because it combines the Medicare and the Medi-Cal in a coordinated plan. Now, for those of you who have been around for a while, you may remember an initiative called the Coordinated Care Initiative, also known as Cal Medi-Connect. That is what had transitioned over into what we have now, which is called the Medi-Medi plans or the D-SNPs. So a Medi-Medi plan provides all of the Medicare benefits and Medi-Cal services in a coordinated way so that the Medicare Advantage plan and the Medi-Cal plan are both under the same insurance company umbrella. The goal is to increase coordination, to provide some additional benefits that are not available if you have separate coverage. So essentially, if a dual eligible beneficiary decides, you know what, I'm going to sign up for this D-SNP, this type of Medicare Advantage plan, their Medi-Cal plan will automatically match. And when I say match, I mean it's going to be through the same insurance company. These are the plans that we have here in LA County. So there's Anthem Blue Cross, full dual advantage aligned, Blue Shield, there's Central Health Plan, there's Kaiser, there is LA Care Medicare Plus, Molina Medicare Complete Care Plus, WellCare Dual Align, and then there's Scan Connections, which is slightly different. But I wanted to highlight these because one change that went into effect as of January 1st is that dual eligible beneficiaries, so again, people with Medicare and Medi-Cal, could make the decision to sign up for one of these plans any month of the year. I talked earlier about the open enrollment period and special enrollment periods. This is a special enrollment period for people who have Medicare and Medi-Cal. Now, these plans do often provide additional care coordination. They might provide some other benefits like, I know at least one of them has like housing navigation, other types of enhanced care management or certain types of supports. These plans are not for everyone. Not everyone is going to want to have this type of a Medicare Advantage plan. Just because you have Medicare and Medi-Cal doesn't necessarily mean this is going to be the best option for you. Because what I tell every client is that before you think about switching coverage, you want to think about, is there a specific doctor or hospital system that I want to keep going to? And if so, you need to check with that doctor or hospital system which plans they actually accept. I would never tell someone who's been going to the same doctor for many years to manage their chronic health condition, yeah, it's fine if you just switch, next month out of the blue. Sure, you could always switch back and make another change, but that gets really disruptive, changing plans every month or every other month. You lose continuity of care. So these are plans that our high cap counselors can certainly talk more about with you on an individual basis. But again, it's not a one size fits all situation. So I mentioned the Extra Help program earlier, the one that helps lower prescription drug costs through Medicare. If you have Medicare and Medi-Cal, you don't have to submit a separate application for Extra Help. You will be automatically enrolled into the Extra Help program, and your copays will be even lower than what I had mentioned on the previous slide. So for dual eligibles, people with Medicare and Medi-Cal, the copays with the Extra Help program for your prescription drugs are no more than $1.60 for generics and no more than $4.80 for a 30-day supply of brand name drugs. So this is significantly lower than what some people are paying for their prescriptions. Now, if you do have the Extra Help program, these are the two standalone prescription drug plans or standalone Part D plans that are available with no monthly premium. This list changes every year. So this year it's WellCare Classic and Cigna Healthcare Assurance RX. In the past, you may have heard of SilverScript Choice or Humana Basic or AARP United Healthcare Saver RX. There's all sorts of different drug plans out there. It's important to pay attention to mail that comes in from your drug plan or from the Social Security Administration about or from CMS about the Extra Help program, because sometimes we talk to folks and they're still on a plan that was $0 last year and now they're being charged a monthly premium. Now, I know this slide looks a little scary with all of the highlighting and the red, but the bottom line is if you have Extra Help, you essentially have the option to make changes to your coverage once a month. Now, would I recommend that you change your prescription drug coverage every month? Absolutely not. Right? That's going to be confusing for you, confusing for your pharmacist, could lead to just confusion all around, really, and potentially problems having, your prescriptions filled. But the good reason that this exists is because sometimes we talk to folks who really, are either the victims of fraud, or, they were away and didn't see their mail, or have difficulty understanding the mailings that come in, don't realize that the plan that they have currently isn't really meeting their needs. And this now means that for people with extra help, we can assist them with getting back into to original Medicare any month of the year, or switching that Part D plan any month of the year, potentially switching into one of those D-SNPs any month. The only thing that cannot be done on a monthly basis here is switching into a Medicare Advantage plan that is not one of those coordinated Medi plans. So if you decide, that you have Medicare and Medi-Cal and you want to switch into one of those non-coordinated Medicare Advantage plans, you would have to do that during the open enrollment period in the fall. But essentially, there are special enrollment periods that make it a little bit more flexible so that you're not stuck in a plan that isn't serving your needs for the entire year. Now, one change, and I did mention this a little bit earlier, that went into effect January 1st, is that for folks that have SSI, are receiving SSI, they are now being automatically enrolled into what's called the Qualified Medicare Beneficiary Program, or QMB, which is where the state will then pay the Part A premium, and they'll be automatically enrolled into Medicare Part A. For a long time, we would talk to clients frequently who didn't have enough work credits with Social Security, and then it was a very complicated process to apply for Part A at Social Security and apply for QMB at the Department of Public Social Services, and then getting that all to coordinate just was really messy, to be honest. They have streamlined this process now, so most of the folks that we have spoken with who are eligible for QMB are being automatically enrolled. If you're not automatically enrolled, please do reach out to us. This is something that we can still help you apply for if needed, but for most people, this will be an automatic process now. Okay, so I know I'm looking at the time, and I am happy to stick around for as long as necessary to answer questions. I have just a couple more slides that I want to get through before I open it up. I saw that there are questions coming in the chat, but I just want to share a couple of common questions that come in, through our helpline from our clients. So one question, I just noticed Medicare deducted $185 from my Social Security benefits. Do I really have to pay for this? The answer is no. If you receive Medi-Cal in addition to your Medicare, the state should start automatically paying for your Part B premiums. Now, we do sometimes hear from folks where there is a problem, where the data is not getting shared correctly, and we can do some intervention with the state to figure out what's going on and get that fixed. Now, depending on what type of Medi-Cal you have, if it's through SSI or if you get QMB, your Part B premium payments might not start until the month or two after you are enrolled in both programs, Medicare and Medi-Cal. But if you haven't seen anything kick in after, I would say 3 months, definitely give us a call and we can try to see what's going on. You will likely get a reimbursement from Social Security if the what is called the buy-in, or the state paying that premium, happens late. Okay, another common question. My doctor's office is charging me the 20% copayment for an office visit. Do I have to pay the doctor? Answer is no. If you are going to a doctor in your Medicare network, or a doctor that accepts Medicare, they are not allowed to charge you a 20% copayment. They are simply not allowed to charge you that. So Sometimes the doctors don't understand that they're not allowed to do that. Sometimes I've talked to clients and they say, oh, well, I didn't give them my Medi-Cal card. So they didn't know to bill Medi-Cal for the rest of the payment. If you run into a situation where a doctor is charging you your Medicare copays, please reach out to us. You can also talk to your Medi-Cal managed care plan, and they can intervene on your behalf as well. And I think this is the last common question. My doctor says that he cannot see me because he does not contract with my Medi-Cal health plan. Is this true? I alluded to this earlier. No, your Medicare provider does not need authorization from the Medi-Cal health plan to see you. If you have original Medicare and LA Care as your Medi-Cal plan, your doctor doesn't need permission from LA Care to see you. All he has to do is bill Medi-Cal for the 20%. Okay, so I know that was a lot of information. I also know there's a lot of questions in the chat, so let me see if I can start going through some of them. Okay. I'm hoping to find out how to qualify for Medi-Cal for daycare at senior centers, in-home companions, and further down the line, assisted living. My husband has dementia. I'm pretty sure our income is too high. So in that situation, I always recommend a Medi-Cal application, regardless of whether your income is too high. There is something called spousal impoverishment protections, where if one spouse needs the Medi-Cal coverage because that spouse has dementia or has other issues going on where they are the ones that need more help, either at home or potentially in a facility, there's the spousal impoverishment protections will allow the well spouse or the community spouse to retain more of the income for, in this case, for herself, um, so that the spouse that needs the in-home supportive services or other care won't get a share of cost. So that's a lot of information for me to try to go over here. But if you're going to write down any keywords, spousal impoverishment protections, and I would recommend applying for Medi-Cal and asking for them to take that into account. We do not assist with Medi-Cal applications at the HiCap program, but I know that there are a lot of great resources out there. We often refer people to either the California Advocates for Nursing Home Reform or to Neighborhood Legal Services of Los Angeles County for more information about spousal impoverishment and long-term care Medi-Cal. So hopefully that's helpful. Okay. D stands for dogs, C stands for choices. Yes, thank you for putting that in the chat. Super helpful. If someone has citizenship for 5 years and 65 years old is eligible for Medicare. So if you're a US citizen, there's no time limit. If you become a US citizen the day before your 65th birthday, or even after your 65th birthday. It doesn't matter if you have lived in the US for 5 years or for 5 minutes. There is no length of stay requirement for a citizen. The 5-year continuous residency requirement is for green card holders only. So, someone that newly becomes a citizen at 65 may or may not have the work credits to get Part A coverage for free, but there's no length of stay requirement if you are a US citizen. I used to get confused Medicare and Medi-Cal. Hopefully that is no longer the case. Okay, so if you receive more than 1732 income from Social Security, you don't qualify for Medi-Cal, age blind and disabled. So that depends. 1732, again, is the current income limit for that aged and disabled program through Medi-Cal. It's going up April 1st, which is literally next Tuesday. So going up to 1801. But they do make deductions from your gross income. So 1732 does not mean your gross income. They will deduct any Part B premiums that you're already paying. any other health insurance premiums that you're already paying. And there's also a $20, any income deduction. And if you're earning money, if you have a job and you have earned income, they calculate that income completely differently. So the 1732 is your quote unquote countable income for Medi-Cal, which doesn't include any of the health insurance that you might already be paying for. Now, that said, they don't care how much you're paying for rent. They don't care how much you're paying for life insurance or car insurance. There are certain things they will not deduct from your income, but the calculation is a little bit more complicated than just, what is your social security check? Because if you're paying for a drug plan or you're paying for a Medigap, which is a Medicare supplement plan, or paying your Part B premium, they will deduct that from your countable income. Are pensions considered income for Medi-Cal? Yes. So when Medi-Cal is looking at income, they are looking at earned income, which is money that you're currently working and earning a wage for the services that you're providing, right? That's earned income. Unearned income is Social Security benefits, veterans benefits, disability benefits, income that's, even though you might have worked in the past to pay into a system, it's currently unearned or sort of passive income. So yes, pensions are considered income from Medi-Cal. And to go along with that, are veterans pension or veteran service connection considered income? Yes, but if you receive aid and attendance benefits through the VA, aid and attendance benefits are not supposed to be counted for Medi-Cal. Now, I know that the VA sends a letter that indicates the total amount that someone is receiving, and it might not break out the aid and attendance benefits from the total amount. So, what you may need to do if aid and attendance is part of the VA pension that you're receiving, you may need to contact the VA to ask them for a letter that breaks it down into sort of an itemized letter. And then you can submit that to Medi-Cal. We actually have a client currently who is dealing with this situation where his most recent letter from the VA doesn't distinguish his aid and attendance benefits. So Medi-Cal counted the whole amount, which put him over the income limit, which gave him a share of cost. So we're working with him to get a new letter from the VA so that we can get Medi-Cal to recalculate his income. Okay, please explain how someone on Medicare can become eligible for Medi-Cal in order to afford long-term care, whether at home, IHSS, or in a nursing home. I'm asking for my mother who's on a fixed Social Security income, no assets, yet does not meet income eligibility requirements to qualify for Medi-Cal. So this is a very common question that we get asked. So we know that as of April 1st, the income limit for the aged and disabled program is going to be $1,801 for a single person. Let's say, just for the sake of argument, that your mom's income is $2,500 from Social Security per month, right? That puts her approximately, what is that, $700 over the income limit for Medi-Cal. And you can apply for Medi-Cal, and what they'll say is, oh, we're not going to totally turn you down, but we're going to give you what's called a Medi-Cal share of cost. Now, I'm not going to go into detail about how they calculate the share of cost. They use something called a maintenance need level. The share of cost is an absurd number that most people are not going to pay on a monthly basis to get access to the Medi-Cal services they need. What we typically recommend is to try to spend what they refer to as excess income on other health insurance, because health insurance payments are deducted from countable income. So in that example I just gave, If someone's income on a monthly basis is $700 more than the income limit for Medi-Cal, this sounds crazy, but what we would recommend is if it's at all possible to find dental, vision, hearing insurance coverage in as many quantities as is needed to spend down that income on additional insurance plans or policies so that Medi-Cal will recalculate the countable income. And I know that sounds crazy because spending $700 on additional insurance that she doesn't need, it seems like a racket. But when you think about how much it would cost to pay for in-home care or pay for nursing home services, it's going to be more than $700 a month. So spending down that excess income on other health insurance and then submitting those receipts to DPSS is usually the best way to qualify someone for full scope Medi-Cal. Now, if they were receiving Social Security disability in the past and it converted to retirement benefits when they turned 65, um, some of those people can actually apply for the working disabled program. And the term work is very loosely used. You don't have to have an actual job. It's very flexible. But those are really the two main ways that we assist people with understanding how to qualify for full scope Medi-Cal. I know it sounds like a total racket, but they will reduce countable income if you're spending money on health insurance coverage. Okay. My mom has private health insurance through marriage to my dad. She also automatically enrolled in Medicare because being on Social Security disability. Is she still able to use her private insurance instead of Medicare or Medi-Cal if she applied? So that is going to depend on the size of your dad's employer. If she is on Social Security disability, the employer would have to have more than 100 employees for the employer plan to remain primary. If the employer is small, then Medicare is going to be her primary coverage and the employer coverage would be secondary. So it's all dependent on the size of the employer. Okay, I mistakenly did not enroll in Part B because of misinformation. While have not retired, my employer coverage, less than 20 employees, is ineligible under my Kaiser coverage. I'm still in IEP and submitted by mail and fax last week. You cannot submit online for Part B only, but my IEP ends this 3/31. Can I apply for an Advantage program without being granted Part B yet? So that's a good question. Um, what will likely happen is your Part B will be effective April 1st if you submitted the application during the month of March. Even if they haven't processed it yet, they should process it based on the month it was received or submitted. So um, if your employer coverage is through Kaiser, you likely should be able to call Kaiser this month and let them know that you've applied for Part B, and that you would like to enroll into the Kaiser Senior Advantage Plan as of April 1st as well. That's what I would recommend doing. And you may be able to request what's called a special enrollment period if that doesn't go through for some reason, related to the misinformation that you received. So that's what I would recommend, but please feel free to contact our agency for more assistance if that doesn't work. Okay, DSNPs. Do they have other eligibility requirements other than having both um sorry, I just scrolled up. Special needs conditions. So for the DSNPs, no, you do not have to also have, diabetes or have some other type of chronic health condition. For a DSNP, the only criteria is that you have full Medicare and Medi-Cal. So you have to have parts A and B and full Medi-Cal. And then you get the drug coverage through the DSNP. There are some types of plans called C-SNPs or chronic special needs plans where you do have to have certain types of health conditions to join those plans. A C-SNP also is a plan that you can join at any time, but like I said, you do have to meet additional criteria for those types of plans. But the D-SNPs, no. Um, Okay, if the person's husband is working, does it interfere with his wife getting Medicare, who is already 65 and a citizen? No. So if you're married and one spouse is working, you may be able to delay your Medicare coverage if the employer has more than 20 employees. If you're turning 65, you can sign up for Part A, but if you have the employer coverage through your spouse and he's still actively working and there's at least 20 employees, you might be able to save some money and not have to pay for Part B or a separate drug plan and just stay on the employer plan until he decides to retire. Um, if the employer plan is very expensive and you want to switch over to Medicare altogether, that's no problem. You can certainly drop the employer plan. You'll have to talk to the employer benefits folks about when you can do that or whether that's possible to do based on Medicare eligibility, but they shouldn't interfere with each other. Some people choose to have both. Some people stick with the employer coverage because it's easier or maybe less expensive and they like it. Some people will switch all the way to Medicare. It's really what your preference is. Um, to find out if my dad has parts A, B, C, and D. So, um, if your dad has Medicare, he can always call 1-800-Medicare directly to get confirmation about what his coverage is. If you need to find out that information on his behalf, our agency can we have a direct line to Medicare. If we have certain information about him, we can call and confirm benefits. Um, you can always check, what cards he has in his wallet, but that's not always indicative because some people hold on to stuff for a really long time and they haven't had that coverage in years. But again, keep in mind, you don't need parts A, B, C, and D. It would be A, B, and D or Medicare Part C, which includes all of those, but either contacting Medicare directly with him on the line or contacting us, that is information we can look up. Is Medi-Cal slash Medicare up for funding cuts now? Oh, goodness. So, great question. I know that there is a lot of anxiety about what is going on at the federal level with all of the proposed budget cuts. And unfortunately, I wish I had a good answer for you right now. Um, Everything seems to be pointing to the idea that Medicaid nationwide will face significant cuts, which therefore would impact the Medi-Cal program here in California. As to what that specifically will look like, I cannot yet say. It could mean cuts to home and community-based services like IHSS. It could mean cuts to supplemental services like dental or vision. It could certainly mean cuts to services for undocumented immigrants, but right now we just do not know what that's going to look like. If you have concerns, one thing I strongly recommend is to contact your member of Congress. I know LA County, for the most part, has representatives in Congress that are very pro Medicaid, but it never hurts for them to hear from constituents about how Medi-Cal has positively impacted your life. Those stories, especially stories about in-home care, nursing home care, those are stories that they need to hear to hopefully help convince some of their counterparts who might not be as friendly to Medicaid policies. Um, Someone asked, what was the name of the neighborhood legal group again? It's Neighborhood Legal Services of LA County. I'll try to put it in the chat. I'm a little bit worried. Well, maybe I'll just read it. I'll say it out loud and someone else can type it in so that I don't lose my place in the chat here. But it's nlsla.org. Neighborhood Legal Services of Los Angeles, so nlsla.org. Is IHSS pay considered income? If you are married, or I believe if you live in the same household as the person that you are providing IHSS to, I do not think it is countable income, but I will be honest that that is not my area of expertise. But I believe if you're taking care of your spouse and getting paid as their IHSS provider, I do not believe that is countable for Medi-Cal. The income is considered what both spouses get for purposes of Medi-Cal or Medicare. So Medicare does not care about your income unless you are a very high earner, and then they'll charge you more for your Part B and Part D. So we're really, when we're talking about income, we're really talking about the Medi-Cal program, which can qualify you or disqualify you based on your income. Okay. Someone said, my dad is retired with the healthcare plan through LAUSD, so I would assume that the employer size would allow her to keep the private plan. Most likely, LAUSD has typically has a pretty good insurance plan. They often don't require folks to have Part A because not every school system, pays into Social Security. LAUSD is obviously huge, so certainly more than 100 people. Most likely she would be able to stick with the LAUSD plan. She will have to have Medicare Part A if she's on disability, because when you get SSDI benefits, the Part A is automatic and you do not have a choice. You cannot turn down Part A hospital coverage, but that's free on a monthly basis, so that should be fine. But I always recommend if there's other coverage, double check with who's providing that other coverage just to make sure, because we don't have details of every other insurance plan. But yeah, most likely if it's LAUSD, she's likely eligible to stay on that plan. Okay. What about transferring funds from joint accounts to a single one so husband has very little funds? That doesn't really make a difference because they're looking at income. They're potentially comparing, information to what you're providing them. The number of bank accounts doesn't really matter. What they are going to be looking at is your total household income. And so that's why that idea of spousal impoverishment protections is very important, because if your combined household income is $5,000 a month, you don't want to end up with an enormous share of cost for your husband. If you could retain most of that income yourself, I think the amount that the well spouse can retain is a little over $3,800 per month. And then your husband wouldn't have a share of cost at all. So again, I do recommend speaking with an expert about spousal impoverishment protections rather than trying to play games with moving around funds across different accounts. If I sign up for Social Security in Part B, am I automatically enrolled in Part A? Yes, as long as if you're receiving Social Security disability or retirement benefits, that Part A enrollment will happen automatically. Okay, I'm just going through. Thank you for the information. That's so nice. We do have Spanish speaking staff that could do this presentation in Spanish. I see that there's a question there. We have resources in Spanish available on our website. And let's see, IHS income is exempt from taxes as a live-in provider and Medi-Cal exempt. Yeah, great. I looks like I made it through all of the questions. Sorry that we went over a little bit, but I know this was important information for you all to get. Please feel free to reach out to us for one-on-one assistance if you have additional questions.
Yeah, listen, this was incredible, Stephanie. You're like this encyclopedia. Every question that came at you, you had answers. And for those that we didn't get to or you didn't get a chance to ask, please know that Stephanie has said call them, let them know about your specific situation, and they will advise you for free, objectively. We also want you to know we will be sending out again the replay We will send out, we're going to try and pull out those questions and answers and put them into a document so it might be a little easier for folks to find what you actually had to say. This was incredible. We will circle back with you and see if we can do a presentation in Spanish. So thank you for the offer. And sister, you had me at the Dunkin' Donuts comment. I'm also a Midwestern girl. A couple of things I just wanted to also bring up, some of the updates that were really positive, right? The $2,000 out of pocket maximum, right? If I heard correctly, that changed, which is great. Also, that Medi-Cal does not have asset limits, still has income limits, but not the asset limits. That was great. Learned so much here. And I know I will not be the only person to watch this over and over again. Stephanie, thank you so much. And to everyone, please sign up for the LACRC email list. You will always be kept up to date on any presentations that we have going on, any support, any kind of additional things to help the family caregiver. We are here for you, just as healthcare rights, the Center for Healthcare Rights is. Thank you, everyone, for joining us. Thank you for your questions. And until we meet again, this is Paulina Milana from Los Angeles Caregiver Resource Center. Thank you.
Okay. Thanks so much for